Good afternoon to all. Welcome to Trivandrum Institute of Palliative Science, and today we have COVID echo sessions. We have two. Today's session have two parts. The first part will taken by Dr. VINEETHA, care at the end of life, and the second part will carried by SMRITI ma'am and Hortusun sir.
Good afternoon, everybody. So today is our last session in the COVID series. So as told before, we know that the death toll is increasing all over world, and most of these patients can be benefited by palliative care. So there comes the importance of end-of-life care. So this session will be taken by Dr. Vinitha Richu, who is presently working at Aster MedCity as an associate in oncology. She has done her MSc in palliative medicine from Cardiff University, and she has been working in palliative care for many years. She is also a member of PALLICOVID Kerala. And the second session will be taken by Ms. Prati. She is the director of director of projects and programs of Pallium India. Basically, she is a psychologist, but she has been working in various capacities in connection with palliative care in various institutions. So I welcome both Dr. Vinitha and Ms. RANA. And first, Dr. Vinitha, you can have your session.
General palliative care, let alone COVID-19. And at this juncture where in this time of pandemic where we are seeing a lot of fatalities, the need to empower ourselves with what has to be done at end of life care. It is very important to know what should be done. So because it is as important as life sustaining, it is life closure is also very important. So can I get to the slides? The first slide, please. Next. Next slide, please. So if you're wondering, where does exactly end of life care, EOLC, where exactly it comes? It's somewhere towards death. Maybe not just right before death. We do start saying defining end of life care about a couple of weeks before death. It could be somewhere about months, even like say about 6 months. Next slide, please. So as you can see, it's a more integrated approach, as palliative care starts on where there is a lot of symptom management being done. There is a lot of planning, advanced care planning done. And throughout, the family is also engaged, and a whole community support, everything is being extended. And slowly, during the trajectory of the disease, as things get worsening, end of life care comes in. And this is usually about a couple of months before life. But in case of COVID, we don't actually have much time. So here we will be dealing with symptom management. We will be dealing with complex decision makings. And of course, the family also has to be given equal support. And finally, as we move on, as the clock keeps ticking and we move on to the last phase, just before death, then a lot of other things also come into play. And finally, on to bereavement and thereafter. Next slide, please. So what exactly is the role of palliative care, end-of-life care, and bereavement care in COVID-19? This session is basically, like I said, to empower each and one of you on how to effectively manage symptoms, to enhance the quality of life until death, until the moment of death, and also to understand how to make complex decision-making conversations with the patient, with the family, and so that you can impart a holistic care of not just physical symptoms, but also psychological, social, and spiritual health. So in short, it is to provide care and support to patients, family, and also your colleagues during the COVID-19 outbreak. Next slide, please. So who are at risk over here? The e-handbook of PALLICOVID beautifully has given an algorithm for the triaging. So kindly please look at that. Those who are at risk are basically the elderly. I would like to stress that when it comes to elderly, it's not a broad term. It's more on what the performance status of the patient is at that particular age. And also some parameters like we could use some tools such as the frailty index to measure these. So the risk group forms the elderly, the frail people, those with already existing serious illnesses or other comorbidities. Presence of COVID-19 may exacerbate already coexisting illnesses, or because of just the lack of reserve, it might create a situation where the patient becomes really sick and that they might die. So in order for dealing with this, we need to enhance our skills of discussing and reviewing advanced care plans to ensure a comfortable and dignified death, and for supporting families and colleagues. Next slide, please. So we as physicians, we have a specific responsibility to ensure that essential palliative and end-of-life care is delivered to two sets of patients here. One, for those who are likely to be in their last year of life because of a pre-existing health condition, and two, those who may be dying as a consequence of the infection COVID-19 itself. So a professional's responsibility is to provide palliative and end-of-life care for symptom control in irreversible situations, and also to support honest conversations about place of care. There are many who might want, or they would like to decide for themselves. Many patients sometimes would like to decide for themselves where they want to die. It is very important that we have a discussion with them, and or probably the family. If the patient does not have the capacity to make his own decisions, the family takes over, and these conversations have to be made as to what are the goals of care that they expect, and what are their ideas on treatment escalation during the course of treatment. So in case of COVID-19, patients generally, most of the patients deteriorate very quickly, and there is not much time left that we can have a detailed discussion. But it is mandatory with whatever possible means that we have, be it telephonic, be it a video conferencing, or even be it within our PPE. We have to find the time to discuss the goals of care with the family, with the patient, and thus form a personalized care and support plan for each patient and have it documented. Next slide, please. So in general, these are the signs and symptoms seen at end of life care. There will be profound weakness, difficulty in taking fluids and food. They could be drowsy, they could have gaunt appearance, difficulty in swallowing medicine, food. They are generally bedbound, and they would need assistance for all kinds of care, disoriented with time and place, difficulty concentrating, unable to cooperate with carers. Next slide, please. If you were to divide the needs of the patient based on just physical and psychological, the common needs, that physical needs of the patient that require assessment are generally nausea, pain, oral problems in terms of oral care that would be required, or even oral feeding, sleep disturbances, confusion, pressure sores because of being bedbound, and the multiple medications they are on, or probably the side effects of the medications, which is in turn increasing the distress of the patient. Nutritional and fluid intake is one of the main concerns of the family when it particularly comes to end of life care, because there is always a question, why isn't he or she eating? How can I feed him on time? So these have to be also addressed at this particular time. And in terms of COVID-19 patients, particularly breathlessness is also one of the main physical symptom that is seen. And psychological needs. Psychological needs, the patient needs to know on the disease and the symptom. We give a lot of importance for autonomy, although in our culture sometimes this is questionable. It is mostly the family that takes over the treatment decisions. Anxiety and agitation also has to be managed, especially with all the stigma and the fear surrounding COVID-19. Patients themselves is seeing their death right in front of them, especially in end of life care. The family not being able to come and meet the patient, especially if the patient is hospitalized, that also adds on concern of about the family and of being a burden to the family. They feel, the patients themselves feel guilty that they are one of the reasons that now the family is exposed. They feel that they have become a burden, and for the family, and for the health workers, and they are worried about how the family is coping. Ms. Smriti will be dealing with all the grief and the associated factors concerning this later on. And also about death and dying, a lot of fear of what is to be expected. Is it going to be painful? Is it going to be devastating? Am I going to be comforted enough? So all these have to be assessed and managed accordingly. Next slide, please. So in short, managing the symptoms finally come down to these 5 important components: communicating with the family members regarding end-of-life care, and managing distressing symptoms like breathlessness, agitation, and respiratory secretions that is usually seen in end-of-life, and uh, providing a holistic approach, addressing the physical, psychosocial, and spiritual symptoms of both patients and their family with compassion. People belonging to different faiths, they would have different religious requirements, and these need to be addressed. But of course, we know that in this time of COVID-19, especially when it comes to the religious practices which is practiced just before death, many of times this is not possible because the patient is isolated, and this all it creates a lot of agony for the patient and the family. And even after death procedures, many of the rites that are usually done uh, are not able to be done because of the precautions to be taken. And there are times when the caretaker or the immediate family member himself is in self quarantine because of COVID-19 and is unable to see the loved one even for the last time. So all these form the major components on end of life care. Next slide, please. So as time goes by, we still keep going on with the physical examination to make sure which point has to be looked into so that more comfort can be promised to the patient. Investigations are kept minimal in the last 48 hours of before death, and medications are brought down to the minimal, and only the necessary medications are given so that comfort care is given to the patient. Next slide, please. The role of nursing care is paramount. So even though the patients are isolated and the the staff is in complete PPEs, there is not much compromise on the care that is given. The usual nursing care, like the oral care, the care of the eyes, of the catheters, like the nasogastric tube which is inserted, or the Foley's catheter, the skin care, prevention of pressure sores, all these things are looked into. And also anticipating probable needs of the patient is also looked into. Generally, when it comes to administering medications for these patients, we try to avoid intramuscular routes for palliative patients to avoid more complications as well as pain. Preferred routes are generally subcutaneous, buccal, rectal, topical, and also syringe drivers are used for continuous infusions. Analgesic sedations are sometimes required when the symptoms become very challenging and it is difficult to bring under control with regular interval medications. Next slide, please. So coming down to the common problems that is seen in the last 48 hours, mainly noisy and moist breathing, which is commonly called as the death rattle. We use anti-secretory agents here, like the hyoscine hydrobromide or the glycopyrronium bromide or hyoscine butyl bromide. These can be given these can be given in regular intervals, or they can be given as continuous infusions in syringe drivers. The doses are mentioned over here, and there is also a decreased respiratory rate that is noticed. A little head end elevation will also help in managing secretions, and a little positioning of the patient to the lateral side will help in the positional drainage of secretions. And in case the secretions are too much, little gentle section also helps. Benzodiazepines are also used when it comes to labored breathing, which we will be looking into next. Next slide, please. Breathlessness in awake patients, or sometimes if it is mild to moderate, we could deal with oral morphine. And if the patients are not able to take orally, IV and subcutaneous routes are also other options. So you could start off with 2.5 milligram to 5 milligram of morphine, generally given both hourly, and it could be increased if the respiratory distress is so severe. It can be increased to higher doses. You could try giving boluses every 15 to 30 minutes until there is a symptomatic improvement. And once the dose is calculated, you can start a continuous infusion. Generally, for severe breathlessness, you could combine it with benzodiazepine like midazolam, which is seen to be very helpful. Next slide, please. Terminal agitation. When it comes to terminal agitation, it is not just about chemical restraint, or I would say it's a big no to physical restraint. Also try to find out what is the reason for the agitation. It could be pain or urinary retention or loaded rectum, nausea, cerebral irritability, anxiety and fear, or it could be just side effect of some of the medications that we are using. So all these things have to be looked into. The commonly used medications for agitation are benzodiazepines like midazolam, and also antipsychotics like haloperidol. You can please refer to also the handbook of PALLICOVID. All these symptom control measures are given beautifully as an algorithm in there. Next slide, please. Finally, coming down to end-of-life care at home, there are a subset of people who probably are better managed at home because they would not need, they would not be patients who would probably respond to aggressive treatment, and we are trying to respect their decision of dying at home. So at this situation, end of life care is managed at home, and isolation is advised for such patients, and the caretakers are alerted on the precautions they are supposed to take in maintaining social distancing, and also care is not completely compromised. They have to use the necessary uh, protective equipments if they have to be dealing with a fecal matter or respiratory secretions. And there are also trained personnels who would come for home visits regularly to check on these patients, so that any change in symptoms, the medications can be revised accordingly. Subcutaneous and IV lines are placed for these patients, and symptom management on which drugs to be administered for which are also kind of educated to the caretakers. Loaded syringes are given of morphine, haloperidol, midazolam, and contact number of the health personnel are also given to the caretakers, so that they are also equipped to an extent to manage these situations when the symptoms go overboard. And psychosocial support is also offered at this point by the COVID trained recruited volunteers, which is very important at this juncture. Community kitchen is also a very important contributor as to helping out people who are quarantined at home. And finally, when it comes to death, the burial is done with all the precautionary measures that is being laid down by the government. And the home of the patient has to go through mandatory disinfective procedures. Next, please. So the basic requirements that are needed are essential drugs, which have to be maintained at the primary health center or the CHC or the taluk headquarters. And PPEs are also to be stocked in adequate numbers. Waste segregation bins and bags, and a good waste disposal system is also mandatory. Next slide, please. So when it comes to end of life care, all across the world, it's been a very challenging situation. Next slide, please. Many of the countries, their end of life care policies and the quality of death have all been studied. And as you can see in the graph, a lot of countries are way behind, and we really have to work for it. And at this point of time, we have to be really quick on it too. Next slide, please. India has already been making an effort to form position statements along with the ISCCM. And there are a couple of institutes that have formed their own protocols on end of life care with the ICU units. And many of them are working really well. Next slide, please. So this is just a small little mental exercise to kind of summarize what we had been looking through all this while. Mr. Govindan, a 67-year-old elderly frail man on treatment for metastatic lung cancer, is having behavioral changes for 2 days. He is completely bedbound, and he's constantly groaning with pain over his head and neck. He has been febrile, progressively breathless since 5 days. There is a travel history for treatment to the red zone area. So what are the possibilities for the causes of his symptoms, and what would you prescribe him? So if we were to think of end of life care for him, and having gone through all the things we just went through, there would be a number of questions that come out over here. There seems to be exposure to COVID, and he is probably contracted COVID. And at this juncture of being in a metastatic disease, now we need to know again, triaging him and finding out what is his performance status, how bad is his disease, is he in a responsive phase, has he been this all his while, and then finding out which symptoms have to be looked into. Is there anything correctable here? Are we going to deal with it pharmacologically or non-pharmacologically? If so, what are the goals of care that we are going to plan for him? Bringing out discussions on place of care, goals of care, and the treatment escalations with the family all have to be planned in this juncture. So with all that, next slide, please. We have come to the end of this half the session, and over to you, Smriti, for the rest of it. Thank you all.
Thank you so much, Vineetha. Sunil just asked me just to facilitate the questions at the end of the session. So I think any moment Smriti will be starting. But thank you for such a lovely, clear, and very well put together, and actually very moving presentation on end of life care. Thank you.
Thanks, Vandana.
Thank you. We're just lovely.
Sorry about that. Hi, everybody. Thank you, Vineetha, very much for that that section on the end of life care. I will be tackling the section on grief and bereavement, and it is a very vast topic. So to squeeze it into a few minutes seems very difficult, especially now that we have this context of the pandemic. But I will do my best. So I'm just going to take a moment to share the screen. One moment. All right. So the learning objectives of this section is just to understand grief and how it is manifested, to understand it in the context of the COVID crisis, and to distinguish between grief and bereavement, identify complicated grief, and also to distinguish between grief and depression, which I've not mentioned here, and to discuss grief in families, patients, as well as healthcare workers. And I think a lot of what healthcare workers are going through right now is also really important to address, because what we're understanding from all reports coming in from across the world, from our colleagues and even people that we're working with, is that the amount of grief that is being felt by providers is also actually unprecedented. So what is grief? And to me, sometimes, words like grief, love, dignity, we all know it. We intuitively know what it means, but it's very hard to pin down a definition. And so here in this context, we're going to talk about grief and the rituals of mourning, which are normally considered healthy adaptations to loss. But now with the current pandemic upon us, a lot of things are upside down, and even for people who've been studying grief and bereavement and all kinds of phenomenon, what we are experiencing today is quite new in that sense. So it makes things a little bit more complicated. So grief as an experience is really a total human experience. And when I say it's a total human experience, what I really mean is that there is an emotional component to it, where you have the emotional aspect, the anger, the sadness that might go with it, the depression, and this immense sense of loss. There's also a cognitive element to it, where people who are grieving have difficulty in concentration, they have difficulty paying attention, they might have a bit of a fog, what's called a grief fog sometimes. There is a social component to grief. People may withdraw from from their families, from their communities, from their social circles. There is definitely a spiritual component to it, where there is a sense of loss of meaning or loss of connection. And those are so important in what makes us human and what makes us really be part of the social fabric also. And physical aspects, of course, grief is felt physically. It is manifested in loss of appetite, loss of or sleep disturbances. It could have several other components to it. It could affect your immune system and energy levels and so on and so forth. So really, grief is experienced at every single level. Dorka and Martin had talked about the fact that there is the experience of grief, then there is expressing it, and then finally there's the adaptation to loss. But again, in this current scenario that we're facing, a lot of that, again, there's a shift in perspective, there's a shift in the experience. Grief, as we traditionally experience, probably are familiar with, that has changed quite dramatically and drastically. And today we have a lot more, we're relying so much now on technology and using it as a medium to stay connected, that even our expressions of grief have to adapt accordingly. How is grief experienced? And like I said, it's a total human experience. So psychologically through feelings, thoughts, and attitudes, socially through behavior with others, and physically through health and bodily functions. So this is just sort of a repetition of what was earlier stated. Coming down to individual styles of expressing and experiencing grief, many of us will probably relate more to one side or the other. And several of us might actually find ourselves in the middle of that Venn diagram. A lot of people who intuitively experience and express grief invest more of their energy in affect, emotion, and feeling, and expressing their feelings and sharing inner experiences. And historically, this has been associated with the way women grieve, which may not entirely be true. There's a lot of gender stereotype also associated with this. But people also grieve instrumentally. That is, they invest more energy in cognitive and intellectual tasks and activities, and they prefer to discuss problems over feelings, and they immediately go into some sort of problem-solving mode. And then there are those in which there's both intuitive and instrumental. Not to say that we are either one or the other. There's usually a blend of both, but we find that one might be more dominant than the other. But there is a dissonant factor where this is where also gender roles come in quite a bit, where men are expected to be the stoic ones, the problem solvers, and for them to suddenly spontaneously express their feelings may not be acceptable as it would be for a woman. So even though they feel all those emotions, they're not allowed to show it, and that's where dissonance usually comes in, when there's a conflict between what you're feeling and what you're expected to show, and what also you might feel is the more appropriate way for you to grieve. In the context of an unprecedented global pandemic, grief is, there are so many different things that are happening, right? There's the economic impact, there's the social impact, there's the professional impact. So and grief being a response to loss, there's a lot of other multiple losses taking place at the moment, apart from the COVID-19 disease itself. And very often when I talk to some of my colleagues, there is a deep an abiding grief in what is being witnessed happening around us. Whether it's the exodus of the migrant workers in India, or whether it's the plight of street children, or whether it's the elderly who are now being even further isolated from their families and from their communities. There's a lot of grief that is now collectively being felt, and I think that is something that resonates with all of us. So really, what this pandemic is doing is it's not just grief doesn't exist in a microsystem anymore. It's actually moved into a macro system. The multiple losses that are faced in a crisis is, of course, there are several, and I'm just going to touch upon a few. There's identity and customary roles, people who are breadwinners, people who've lost their jobs, stay-at-home mums, and now work-from-home dads, and everything is on its head, and everything has changed in that sense. A lot of people who were the anchors in the family probably are not anymore. Who do you identify more as a healthcare provider, or as a mother who has a responsibility towards her children or to her elderly parents? I mean, there are several conflicted feelings around roles and identity at the moment. Bodily function, in the case of the people who are affected, yes. Relationships might be under serious stress at the moment. There is, of course, material and economic losses that people are experiencing on a massive level. I think all of us are quite aware of that. I'm not going to go into detail. A loss of time. So many of us had aspirations and plans, things that we were going to achieve in the year 2020, which is probably going to be a seminal year for a lot of us. But those, time as we know it has also sort of shape-shifted a bit, and opportunities have been lost in the process. Children who were supposed to take their board exams, who were on the brink of a new future, all of that is gone, for the moment at least, and all this uncertainty has taken its place. So all of these things do feel like losses. They are losses, and these are things that all of us grieve over. And like I said, remember that most people are experiencing multiple losses simultaneously. So it's grieving over several things at once at the moment. So the scale at which we're experiencing grief is also completely different. A quick word about anticipatory grief, because that's an important part of what grief is. Grief that is felt in anticipation of a future harmful occurrence. And in this time of uncertainty, where we don't know, when statistics are changing from minute to minute, day to day, the guidelines that we receive, the advisories that we receive, the information that we have, the medical information, the coping information, everything is changing. And we don't quite know what's going to happen. And there seems to be this pervasive sense of doom that's all around us. And especially if we have people in our orbits who are especially vulnerable or susceptible, then there is an anticipatory grief there as well, because we're also worried about what might happen to them. So in the context of the pandemic, that's how I would probably frame it. But anticipatory grief, as we have always known it, is grief that is in anticipation of future harmful occurrence. It is directly related to awareness of an impending loss and its emotional impact. And this can also be extended, beyond relationships, to jobs, to any other phenomenon in our lives. And there's a huge component of fear when anticipatory grief is in the mix, and the fears may be about the unknown, which is something that all of us are facing at the moment. We don't know what things are going to look like even 6 months, 3 months, 2 months down the line. Fear of loneliness, that is especially exacerbated. That is especially true now, because more and more we're isolated, and we are separated from one another, from people we might love, and there is that fear also that exists. Fear of loss of family and friends, the fact that we might, someone might get the virus, that something drastic will happen. And the way this virus, the way this disease trajectory is, that if somebody does get it, you really don't know which way it's going to go. And that loss is also very sudden, it's very dramatic. Fear of loss of body function, I mean, that's quite self-explanatory. And fear of loss of identity. These are some of the typical things that anticipatory grief sort of works itself around. And if we put it in the pandemic context, of course, all of this, like I said, is enhanced. I'd like you to think about grief, not just in terms of what patients and their families are going through, but also what healthcare providers are going through right now. And like I said at the beginning of the presentation, that a lot of us are experiencing grief, and I'm going to touch upon that particular aspect in just a bit. In the setting of the COVID-19 crisis, because of its rapid onset and fast progression, the experience of grief itself is altered. It's compressed, it's accelerated, and it's really something that we've not really dealt with before. There is, of course, like I said, increased uncertainty and increased anxiety and isolation for patients as well as their families. And what really that puts us in the position of is behaving like a bridge. The healthcare provider, we have to function as bridges between families and patients when they're separated from one another. As a lot of my colleagues have shared in previous presentations, that the PPEs do hinder empathetic communication, and I know Dr. Biju has talked about how we can get around it and put a smile in your eyes and things like that. But this is something for us that we're still getting used to. And the fact that people cannot participate in traditional rituals and funerals, this really causes a loss of closure, and it takes away that really, really important part of grieving and bereavement, which is to really, close the loop on a particular experience. But that's not something that we can do in these times, and we're literally robbed of that privilege. So, for paucity of time, I'm just going to quickly just touch upon some of the things that we as healthcare providers can possibly do at times like these. When it comes to communicating with family members, we need to understand that uncertainty is a huge cause of anxiety. And usually when there's uncertainty, we fill those gaps with our imagination, and our imagination usually tends to imagine the worst case scenario, right? And so it's very important that whatever little information we may have on hand is communicated as clearly and crisply as possible. Maybe you might have to do it multiple times, but try and, to the best of your ability, remove as much uncertainty as you can. This also has been talked about on several occasions, the use of available technology to stay in touch with families. So I'm not going to go into it in much detail because it's been covered. It's very important for us to avoid jargon at this point, because we might understand jargon, the medical language really, or the psychological language in my case, quite clearly, but the average person does not. And actually, by using jargon, you're making the problem worse, because as it is, we have very limited time at this, in these situations, and we're hindering the understanding that the person might be able to have of what you're trying to say. So give clear information and avoid jargon. Try and speak in lay speak as much as possible. Definitely try and talk to more than one family member. It might be difficult, but it's important, because under such high anxiety and stress, someone may not process information as you mean it. So there is room for misunderstanding. There is room for not really understanding what you said. So if you talk to more than one family member, you actually able to make sure that the family as a whole has understood the information that you're trying to communicate.
No. I just
If symptom control is achieved, it must be shared with the family to prevent them from wondering if their loved one is suffering. If I'm not able to be with my loved one at a time when they're most vulnerable and when they're most distressed, like I said, The uncertainty may lead to anxiety and to imagine the worst. And to me, the worst possible scenario is that my loved one is in extreme pain, is in extreme suffering. So it's very important to communicate when good symptom control is achieved, because that would be really appreciated by the family. A time of high anxiety also means a lot of lashing out. And I'm sure all of you as physicians have experienced this at some point or the other. It might be enhanced at this time. So while it's very difficult because emotions are running high, even amongst healthcare workers as well as families, it's important to try and center yourself and remember not to take the emotional responses of family members personally. Everybody who we've spoken with feels guilty in some way or the other at a time like this, when they haven't done enough. There's survivor guilt, how come it happened to them? Why did it happen to me? Did I bring it? Was I an asymptomatic carrier? Did I somehow contribute to my family member getting it? There's a lot of guilt that would float around. Be ready for it. And it's always important to, as kindly as possible, tell a family member that they did their best. We can only work with the tools that we have available to us at the time. Sometimes they are inadequate, but and hindsight, of course, is 2020, isn't it? So we always know what we could have done better once it's over. But in that moment, everybody is doing their best, and it's important for the healthcare provider to try and communicate that to the family at some level, because there's already a tremendous emotional load on the family. Guilt is possibly the worst thing that they need to feel at this point. A small exercise which has worked and may work in this setting is also to ask the family to describe the patient as a person to you. Because it's so easy in the load of work that we're buried under to forget. I mean, even though in palliative care we constantly talk about treating the person and not the disease, but it's nice to hear from the family what they think of the person, what that loved one means to them, and by allowing them to describe the person to you, what you're really telling them is that you care about what role that person had played in their family, what he or she means to their loved one. And so that's a quick way also to build rapport with the family. Offer to pass on messages to the patient. Of course, we're reading a lot about how healthcare providers over the world are doing this. And if family members struggle with what to say, suggest the following prompts. This is something that we came across, and what it says is most people in this situation, what you could say is, to the family is, most people in this situation say something along the lines of, thank you, I love you, please forgive me, or I forgive you. And with these prompts, you can actually get them to say some of the most important things that they might need to say, but in that moment of anguish cannot find the words. So these are good prompts to give them. Care for the family from the point of view of our institutions and organizations, setting up, getting together teams of social workers and volunteers, try and have early conversations. So, for example, what we've done here is we've set up helplines where our social workers are calling our regular patient base, but also we've opened it up to the public. And these early conversations go a long way in alleviating some level of anxiety and distress. Also, helping a person with acceptance. This is a very, very difficult thing to do, especially at a time like this when it's outside of our realm of normal consciousness. I don't think any of us have really experienced something like this. So help with acceptance that this is happening is key. And support for pathological grief, which I'm just going to talk about in a minute, and care for the children. These are important things to look at, but each of us may have different challenges while we're working with these aspects. So what is the need? What is our capacity to meet that need? All of those things need to be taken into consideration. Okay, moving on from grief to bereavement. Bereavement is the actual event which is associated not just with death, but also changes in relationships. A divorce, is often felt like a bereavement. a loss associated with economic status, geographical location. So bereavement is basically the objective event of loss. In the context of the pandemic, this becomes a far more complicated phenomenon, because everything that we have traditionally known has changed in terms of societal mourning processes, right? And funerals, burials, gatherings are all governed by strict government guidelines. I recently met somebody who attended a virtual funeral of her aunt, and only 4 people were allowed in that church, seated in the far corners. And when I asked her what it felt like, she said, "I really don't know. It felt surreal. I felt disconnected." So it wasn't even like you were there. And I also met a chaplain who has recently conducted a funeral virtually, and she's in her late 70s, and she said to me, she said, "I never thought I'd live to see this day, where I would have to virtually conduct a funeral." So this is really a completely different world from what we're used to. I just want to, touch upon the fact that very often grief and depression, not to people who worked in the field for a long time, but to a lot of people working with this, just sort of getting into this whole space, it's important to make this distinction. And while they share a lot of similar characteristics in terms of, the experience of it, this is something that we need to remember, that grief, right through grief, it is possible for a person to stay connected to others, periodically experience pleasure, and to continue functioning as he or she rebuilds their life. But in depression, there is a sense of loss of connection and an inability to experience pleasure. And so these are some of the key differences, but also the duration that this extends into is very important. And the Diagnostic and Statistical Manual of Mental Health, the 4th edition, did not allow for the diagnosis of major depression for 2 weeks, to be made within 2 weeks of bereavement. But the DSM-5, the following edition, did make a distinction, and they eliminated bereavement exclusion as a criteria. And they said that it is possible for depression and bereavement to coexist. And you cannot say that, grief will only last 2 months, and only after that can you say that depression can exist. So there are all these differences that they had outlined earlier. So the difference between bereavement and major depressive episode, I'm not going to go into each of these, just being mindful of the time, but I'm happy to share this. But as of now, with the latest edition, there is a lot of debate. It is a controversial edit, but they have eliminated bereavement from the criteria. Okay. Complicated grief is intense and a long-lasting form of grief, and where the natural healing process is derailed by several factors, which include what sort of a relationship you had with the person, circumstances of the death, and events that occurred after the death. So in a non-pandemic situation, the nature of the relationship, it could be a complicated relationship that you have with the person. It could be with a parent who was abusive. It could be with a very enmeshed relationship. The circumstances of the death could be, maybe stigmatized in a sense, a drug overdose, a sudden accident, a suicide, and events that occurred after the death. So something unpleasant that might have occurred after the death, either at the health facility or in the handling of the body, or some information that may have come out from within the family. All of these things might cause complicated grief. But in the case of a pandemic, it's more than likely that grief will be complicated because of the nature of the way this has evolved. And it tends to dominate and overshadow life, and certainly requires professional intervention. This is an algorithm that my colleagues at PALLICOVID Kerala developed when trying to navigate the whole process of grief and bereavement in the context of the pandemic. It is a very helpful algorithm. It helps you to identify distress using different parameters, identify grief, and then rule out depression, assess risk for suicide, and of course, then it gives you targeted psychosocial interventions. So this is a very handy algorithm. You'll be able to see it in the ebook once you downloaded it, or if you just turn to the chapter on grief and bereavement. Final word on healthcare workers. While we look towards caring for our patients and their families, don't forget about yourselves. There is a tremendous amount of trauma that is faced in these times, and even if you don't have to be a frontline worker. That's something I want to emphasize, that you don't have to be out there in the trenches looking after COVID-19 patients to be experiencing the trauma and the vicarious suffering that is prevalent around the world at the moment. There is something to be said about disenfranchised grief that healthcare workers provide, that healthcare workers go through. You can feel grief for your patients. Just because you're a doctor or a nurse does not mean that you're immune to these experiences. And a lot of times we hear people say, oh, but this is your job. But that doesn't stop you from being human. So there's a lot of disenfranchised grief. I'd like you to be aware of it. Grief over your own relationships that may be changing in the current scenario, not being able to be with your families as much as you'd like, or having to make a moral choice between your duty and being with people you love. Not being able to spend time with your children or with elderly parents and so on, that brings its own kind of grief. Multiple losses that healthcare workers themselves might be going through at the moment. There is role conflict. There's a lot of role conflict going on, and that is something that can cause an immense amount of anxiety and emotional distress. And of course, guilt for not doing enough, guilt for not being on the front lines, guilt for being on the front lines and not being at home. I mean, there's 10,000 reasons to feel guilty at the moment, but really it's something that is not helpful. And if you find that you're being overwhelmed by these kind of feelings, do reach out. There are communities, and I think one of the few good things that has come that we're seeing emerging at this time is that there is more focus on mental health, and more and more people are coming forward. They recognize that the mental health of healthcare providers is so important, and that is something to tap into. There are resources available, and it is an act of courage to ask for help. So that is something that we all need to remember. So I'm just going to end with this quote, which is by Jamie Anderson, and he says, grief, I've learned, is really just love. It's all the love you want to give, but cannot. All of that unspent love gathers up in the corners of your eyes, the lump in your throat, and in that hollow part of your chest. Grief is just love with no place to go. So I'm going to stop with that, and over to Dr. Sunil.
Thank you so much. That was absolutely fabulous. Gosh, you guys on this webinar today have had 2 excellent sessions. I think there's so much we could talk about, and you've come in on a Saturday too, so thank you for that. Does anyone have any questions initially for either of our presenters today? And when your questions, you can put them on the chat. You can ask them in a way which is more sharing your experience, or you can ask an actual question, say a factual question. I'm going to try and see who's on our calls. We have George, you've been here every day, thank you. Navjeevan, you were telling me how much on chat, you were telling us at the beginning how much you've learned from these sessions. Rajani, you've been contributing all week. So anything that anyone would like to say? Okay, then I'm going to just ask you a question, I think, to our last speaker. I think you brought up this whole issue of trauma and grief. I wonder if you could just think of ways in which we could support one another. You mentioned about looking after ourselves, but perhaps also in palliative care or in the areas we're working in, people will come to us. Any just practical suggestions of how we can do that, how we can stop being overwhelmed by the trauma that we're seeing around about us? And that's just SMRITI.
So from audio, okay. Thanks, Moira. I think, I mean, we've been talking about this in some circles as well, that we talk about self-care as something that is essential, and it is. But it's also important for us who work with organizations and institutions to remember that when we ask someone to, look after themselves and make time for self-care, we have to ensure that we as an institution make that possible. If I ask you to find time for self-care when you're doing a crazy shift, that's not, I mean, I've said what is appropriate, but it's unfair. So there's two aspects to self-care. I think one is that the institution should definitely provide that space to support it. Secondly, I find perhaps that at this point, reaching out to peers is really helpful, because it's really a very the positions that a lot of people hold at the moment who are in healthcare are not easily understood by people who are not in healthcare. And yes, there is mental health support. There is probably a lot of family support, but I doubt that every single person has that kind of support system. So there are already several forums that have come together that are utilizing different kinds of methodologies to support healthcare providers. I would say that tapping into those resources would be very, very important, because there are people who have worked with resilience building practices that can be imbibed at a time when you're in the thick of it. And I think there's a lot of really good work happening there that's easily accessible. So that's something that I can think of suggesting at the moment, but I'm sure VINEETHA has probably might have something to add as well.
Thank you, Smriti. Would you want to make a comment, VINEETHA? And maybe you could also say something. You mentioned something about how you might facilitate people to have those final conversations. I wonder if you could say something else about that in the context of end-of-life care. Thank you, VINEETHA. You have to unmute yourself.
Yeah, I did that. I think this is end of life is a point of time where you don't get a second chance. So there should be some way that, of course, with the adequate resource of PPEs, we should be able to facilitate the last conversation, at least with the loved one, be it even in the isolation room, rather than having not to see at all. But of course, otherwise, we do have safer options like the video conferencing, which should be allowed on a regular basis. But other than that, we are just working around so many precautions, and it's a bit unclear. So yeah, hopefully we can work out something.
Thank you. And Smriti, you talked about the healthcare team being like a bridge in that situation. And Rajini's come with a very important question. We've talked about the trauma of not doing our normal rituals. Are there ways in which we can help either alleviate that trauma? Or I wonder, I'm certainly thinking about whether there are new rituals we can help people to have, which are just as meaningful, but are very different. Smriti, any thoughts yourself?
This is I find it, well, I guess it's a bit of a difficult question to answer, Moira. I won't shy away from saying that this is all a bit overwhelming, and I think when you talk about new rituals, I think we're all sort of feeling our way through the dark at the moment, and they are evolving as we go along. There's also, I mean, I'm not actually providing any solutions. I'm just restating the problem, really. And I think a huge concern is, what happens? Okay, there's the virtual funeral, but after that, people are still at home by themselves. This, in the immediate aftermath, where earlier you would have a wake or you would have some sort of gathering to remember the person who has passed on. We don't even have that. So I suppose new rituals using technology would be to have those gatherings, to have those memorials, to reach out in the most basic human way. Because I don't think there's any sophisticated intervention that has been designed for this. And really, what we're finding more and more is that it's that basic human connection that's all we can offer each other. I would also, just as a side note, I want to add that it's very important for us as healthcare providers to be okay with our own vulnerability at this point. Because if we're going to try and solve these problems and try and be there for our patients, for their families, it's impossible. It's impossible. So we need to be aware that our vulnerability is not something we should be afraid of. It can be a source of courage also. So yeah.
Thank you so much. I've been seeing some really moving episodes where some of which I've been involved with, where people are, hundreds of people lighting a candle at a certain time as part of the remembering, or people who are, sharing poetry or words, but doing it in a virtual way. So it's not just the virtual attending of the funeral, but it's the remembering and the storytelling and the narrative, which is actually what those rituals are many times about, aren't they? As well as, of course, the faith context that may well be very important. And perhaps there's a way in which some of those formal things can be delayed. There may be, a death anniversary rituals, which of course are very common in some cultural and faith settings. But it is also moving to see how creative people are being in still having that connectedness without the physical presence. Yeah. Sure.
And I think this is a time for sort of enhancing symbolism, because really,
yes.
it's really important that, and I think we have lost touch with that in the last few decades, when there's been a race for, being, what I'm talking about. So this is perhaps a time to return to those basic art, that art of symbolically connecting, or also just sorry, it's been a long week. Yeah. So you know what I mean, yeah. So symbolism is place right now, yeah. I think that's really important.
Yeah. Anyone else wants to ask a question or make a comment? You perhaps have all had a long week. George, I always see you looking there very, very attentive, but being quiet. Do you want to make a comment? You have to unmute yourself so we can hear you. You're still muted. Can you just press unmute on your screen?
Thank you very much. Thanks to all.
That's a lovely comment.
That's very nice.
Lovely. Anyone else has anything they want to contribute?
I just want to thank everyone who's been so generous with sharing their time and their knowledge and expertise over the last 1 week. Very grateful. Thank you.
Thank you so much. And of course, from our perspective as faculty, it's only worth something if people are there to share their experience with us too. So thank you for that. Delighted to remind everyone that these COVID sessions, ECHO-COVID sessions, will continue, but there's also going to be webinars, standard webinars on all of these topics produced, so that you can also deliver them in your own settings in whichever way works for you, using local examples. And a real thanks to the technical team as ever for the huge amount of support they're giving us. I think if there's no more other questions, we'll thank both of our speakers very much, ask them to take some rest and to look after themselves, having just given to all of us. And I wish all of you also a good day's rest. Tomorrow is not a rest for everyone, but it is for many. So please do take some rest, enjoy some beauty, go and see a beautiful bird. I've just been watching a sunbird outside, and just be rejuvenated for next week. Okay.
Thank you.
Okay, and back to the ECHO coordinator.
Bye.
Thanks, everybody.
Oh, yeah, you have to remember your form. Don't forget your form.
Okay, thank you, everyone. Please attend this feedback, because your feedback is extremely important for us. Please attend this phone and put your feedback. It's a request.